started. I think as Allon is joining in, we would love to hear introductions from our panelists, esteemed panelists here. I only see Matt and Dr. Robert Pearl at this time. Gloria, are you able to turn on your video?
Let me try again.
Okay.
Yep.
Oh, there we go. Yes, fantastic. Welcome. So let's start with a brief introduction in maybe like a couple of minutes, a share introduction about yourself, your background, and then what made you decide to disrupt healthcare, and then talk about your company. On my screen, so I'll go around the tile. So I see Dr. Robert Pearl as the first tile next to me. So Robbie.
Well, thank you so much for having me. My background is that I'm a physician. I fix children with cleft lip and cleft palate. I was the CEO in Kaiser Permanente for 18 years. Since then, I teach at the Stanford Graduate School of Business and Medical School, and I'm now the executive chairman of OnLive, which is a new company that is focused on disrupting and changing American healthcare by raising quality, increasing convenience, and lowering cost, which a lot of people say, except that we have a specific approach around it that has primary care connected as a base, but it does things that no one else does, which is to bring the specialists into the exam room to take care of the 40% of problems that primary care knows enough about, but not quite enough about, but with a little bit more knowledge they can. And it has very low cost global care associates who are able to provide 2 and 3 times more support, mathematically 5 times more on a cost basis, to primary care, to specialty care, and to the patient. And this combination of support and integration is the magic sauce that allows the patient to have the better experience and the physician to be more satisfied. And in terms of how, why, and when, I've been a rebel my whole life. It's part of why I came to Kaiser Permanente in the first place. It's part of a lot of what I did when I was there, including 12 million virtual telehealth visits. And it's why I joined Hitesh in starting the OnLive program, and hopefully I'll have a chance to talk more about it later today. He'll be on the program later in the afternoon to provide some more details.
That's fantastic. So we'll call you the rebel on this panel. Okay, fantastic. Okay, next, Matt, you're next on my screen. Thank you.
I like that. I hope everybody gets a nickname. That would be ideal. So I'm Matt. I'm the co-founder and the CEO at Eden Health. At Eden, our mission as a company is to create a world where every person has a relationship with a trusted healthcare provider. We really view that trusted clinical relationship as the beginning to any good patient experience or health outcome, as well as the beginning of long-term savings to the system, and by making sure that folks have easy access to the essential parts of care. For me, I've watched family members go through traumatic health experiences over the years, and the difference between a family member who's able to find a trusted clinical relationship that can help guide them through the confusing process of healthcare and those who don't are stark. And, it demonstrates not just on the physical side or mental side, but, it's in some ways can be as difficult as managing the disease in terms of managing through the health system. So that's why I'm motivated to do what we do. At Eden, we provide a hybrid care model. So we do care virtually. About 75% of our clinical interactions are virtual. We operate in all 50 states. And about 25 operate in person out of our locations, as well as our providers who provide mobile care. And we provide primary care. So that's your acute, preventative, and chronic care. We provide mental health. And so that's in a collaborative care model with our licensed social workers and psychiatrists. And then physical therapy. And that's really supercharged with navigation, where similar to what Dr. Pearl was talking about, we bring specialists into the do peer-to-peer consultations at the primary care setting to do more care at primary care without needing to refer externally. But when we do refer externally, guiding folks through that whole process. So we think about it as a health system. We partner with employers as well as insurance carriers and TPAs and others to bring this to our patients.
Awesome. Can you share how many inpatient clinics you have at this time? You mentioned 25, right? At this.
In terms of clinics?
Yes.
So we have, by the beginning of next year, about 18 locations across the country, and we're opening up more. So coming to a place near you.
Okay.
But virtually is our primary format.
Yes.
For care.
Yes.
Matt,
75%.
Matt, what's your nickname?
I thought that I was supposed to be given that nickname.
Yes.
But I need to come
we call you Trusty.
Okay.
Because you're building trust. So
Go.
and Trusty. Okay. Gloria, you're next on my screen.
I need to give myself a nickname, right? Like, so I think I can be the fake doctor. I have a PhD, but not an MD. So my family calls me the fake doctor. So my background's pure technologist. I have a PhD in engineering, again, not, like the right PhD. And I am a consulting faculty in the engineering school at Stanford. Most people know me through sort of like data science, machine learning, AI. That's my entire career. I got into healthcare for a very personal health reason. I had women's health struggle when I was at Google. And it was, like everybody had one of these stories, right? Like it was like super fragmented. I was my own quarterback. I was bounced between OBGYN, PCP, dermatologist, allergist. And that whole experience left me wondering, hey, like what's wrong? It obviously cost my payer a lot of money and me a lot of pain. And ultimately it took me way longer than it should to resolve the issue. It's not a simple issue, but it's just very frustrating. So that's why I got into healthcare. When you look at what we build at Alpha Medical, so I'm the co-founder CEO of Alpha Medical, the simplest way to think about what we do is that we're virtual primary care for women. So we're purely virtual and virtual only. We do a very broad spectrum of primary care and we focus on women. So that's solving a very personal issue for myself and for half of the population.
Excellent. So are you calling yourself the fake doctor here?
I don't have a better nickname. I have to think about that.
How about we call you the woman doctor?
I'm not a real doc.
Yes.
Can't diagnose.
Yes. Perfect. And Allon, we can't see you or hear you. Welcome. We will need to make, here we go. All right. Nice to see you again.
Likewise. Sorry, it was telling me you need to open it up. So
yes, we did. So what we're asking folks, and you've gone through this format before, is if you could introduce yourself, why did you decide to disrupt healthcare, and talk a little bit about your company within like maybe a couple of minutes, and then we are also creating nicknames for people so you can ask questions. Yes.
I always wanted a cool nickname. So. I am originally from Israel. I've been in the US for most of the last 20 years. I started a couple of companies and ran them, including Vroom to buy and sell cars online, and Wix, to the big web publishing platform. Both are public on NASDAQ. I started K just over 5 years. On November 1st, it was 5 years, really around kind of a personal desire of mine to get direct access to medical information, not through doctors, but enable me, and everybody else to get direct access to information and essentially teach a machine the language of medicine. And so that's how we went on the Odyssey. We didn't have a big plan or business model, but it was really around the concept of giving people direct access to information. And then slowly we started building a big information layer, but also a big services layer. So we have a lot of users that use us for free. We have a lot of users that pay us. We have a direct-to-consumer model that people use us for out-of-pocket stuff for both acute care and chronic care. We have our own pharmacy as well. And then we also have partnerships with Mayo Clinic around data and with Anthem, Blue Cross, and other insurers. So we're in early stages there, but we're in the employer market as well. I think we raised around $400 million to date. And we have a fairly big team, so it's grown a lot over the last, every year it's grown a lot. So that's kind of where we are. We do everything we do online. We refer a lot of people to offline tests and labs and treatments, etc. We focus online. We have a 24/7 service, not 50 states like Matt has. We have 48 states. We're not yet in Alaska and Hawaii. And we do it 24/7. And like I said, we do primary care, including chronic care, complex chronic care, acute care, some elements of preventative care. But again, from my perspective, we're just getting started.
Excellent, thank you. So I'm going to give it back to Bambi, but I was thinking of like Dr. Alpha for Gloria, and then Cool with a K for Allon. How's that?
I like cool.
Yes.
Or it could be access. I know Allon's all
Access.
about access, being
Yes.
Mr. Access, and I like Alpha for Gloria. But this one's for Rebel Robbie. Rebel Robbie's been I think you were CEO of Kaiser Permanente Medical Group for 18 years, has one of the largest, if not the largest, medical group. So, and Archana and I had the opportunity to speak with Robbie on a podcast recently. And one of the things that really stuck out was what you were able to do at Kaiser, not because of the technology, but because of the economics. And we have now, this panel is largely around economics, but clearly around technology, because we have a number of technology innovators here. But as you think about all the changes that are happening, what is more critical? The technology advances, because we are creating lots of efficiencies, as we see even with just telehealth, or economic model changes? And I know you can say both, they both have to need to happen, but which one do you think needs to be a real priority?
If I can lay a little bit of foundation behind it, I've written 2 books at this point. One's Mistreated, about the system of medicine, fragmented, paid on a piecemeal, called fee-for-service basis, the technology left over from the last century, although it's really from the century before, it's the fax machine, and the lack of a complete leadership structure anywhere in it. And more recently, I wrote a book called Uncaring, about the culture of medicine. And you're right, it is a question of both, but there is one, I think, that leads the other, which is I do think the economics lead the culture, by which I mean, when you're paid on a fee-for-service basis, you do more. I spoke about a year and a half ago, before COVID, to the CEOs of the 50 largest companies in the country. And I asked them, I said, how many of you have remodeled your kitchen or a bathroom? Of course, every hand went up. And I asked you, how many of you told the contractor, do whatever you want and I'll pay you time and materials? Now, money isn't an issue for these guys, but none of them raised their hand. Now, why? They think that contractors are dishonest and doctors are all honest? No, I teach in the business school. These are the incentives that drive people. When you're capitated, you focus on prevention. When you're capitated, you avoid complications from chronic disease. You focus on patient safety. And when you're capitated, you elevate primary care. And rather than focusing on the individual, you focus on the team. And by that, I'm talking about the primary care physician and the specialist. I'm also talking about the other members of the team. But for the panel today, I think it's important to understand that. We were able to control hypertension over 90% of the time. Of course, the US today is 55%. Everyone knows hypertension is the leading cause of stroke, heart disease, kidney failure, all the other causes. Why? We had good doctors, so did the community. We had great medications, but so did everyone else. It's the fact that we were able to involve everyone in that process. If you make control of hypertension or diabetes solely the responsibility of primary care, they can't do it. You give them a team of people, they can do it. But it's pretty expensive if they're going to be nurses and other individuals. If you say every time you see a specialist, we're going to focus on the area too, and provide the technology to allow you to understand what does this patient need and allow you to provide it at the time, now you start to see those pieces rise. And you start to see, as I say, 7 years ago in Health Affairs, I published an article about 12 million virtual visits. The rest of the world wasn't doing that much put together. We were doing it in Kaiser Permanente. Why? Because telemedicine is faster care, more convenient, and lower cost, and in a capitated system, it works. So to answer your question, I think the economics drive the culture, and it's the economics that drives the culture that then allows us to decide the technologies that we value and those that we don't. In a fee-for-service world, what do you value? Robots, $2 million machines that have never been demonstrated to extend life by a day. What do we know in primary care? Add 10 primary care physicians and you increase life longevity in a community 2.5 times more than adding 10 specialists, but we don't value that in medicine. It's not just the economics, it's the culture, the technology comes along with that.
I'll just add to that, that if you don't have a culture that values the economics, you will have a new ushering of a new group that values that culture. I mean, those economics, and they will be elevated and they'll sweep to the side all the others who don't value it.
You know, as we said on the podcast, a decade ago, I said to people, you know, that 10 years from now, the company that rents the most cars won't have any cars. The company that rents the most houses won't own any houses. The company that provides the most content won't produce any content. You'd say I was crazy. And today, that's, you know, Uber, Airbnb, and Google. That's what exists right now in medicine, with the culture that exists. The technology that is going to raise quality and lower cost is not valued because it's not a technology that supports the economics. So I think all of that has to change. You know, medicine is the only specialty, the only industry I can think of, and I've studied a lot of them in the business school, where over the past 20 years, the combination of AI, data analytics, computers, robots, you name the technology put together, has raised costs. Every other industry that I can think of, it's lowered it. And the reason is that the technology isn't any good. It's the culture and the economics that come together that prevent it being used in the right ways.
Yeah, I can't agree more on why we need all the trifecta of healthcare to align together, which is the patient, provider, and the payer. And the payer sits behind the background, and I think that's what is driving the cost in the wrong direction. With that, we would like to focus on the approach that each one of our panelists are taking, especially changing the PCP role to support or moving the business model in that direction. So my first question is for Dr. Alpha. Why did you focus on women's health, and especially virtual only, considering women like the in-person interaction quite a bit? So if you could elaborate on that.
Yeah, I mean, like I said, it's a very personal journey for me. I have women's health issue. I'm sure lots of you share that. And that's the first and foremost, right? Solving a pretty personal issue for myself. But when you look at it from a business standpoint, it makes sense, right? Like lots of studies show that, hey, women is the chief medical officer in the family. Like I manage my kids' health and myself, you know, I'm an elderly parent. So that's the best entry point. Women tend to spend more in healthcare. And actually, so when you think about the overall equation, right? Like when we look at the population, when we look at the patient we serve, they tend to be actually more underserved. So they don't live in San Francisco proper, they don't live in New York City, where access is truly challenging. It's right outside of those major metropolitan areas, right? So it is like Duluth, Georgia, it's like right outside of San Francisco. And there, the way to bridge the gap in care really is through virtual. This is what we think, you know, needs to happen. And when you look at the broader picture, right, like 80% of stuff can be treated online, and we do all of those. The rest of it, we make referrals. So that's how we think about this too. And the other side of this equation is the fact that, hey, like given our patient demographic that tends to be, you know, slightly lower income, I can build clinics in whatever zip code it is. I can't change the supply side of PCP by building clinics, right? Like I can birth more of them. So when you think about how do you bridge the gap in care, for us, virtual makes sense. And back to what Dr. Pearl, sorry, your nickname, the rabble.
Yes.
So back to what the rabble said, right? Like I totally agree that like the economics drives everything. Technology supports that, right? So for us, it's really about bringing costs down. Like how to bring costs down, right? Like building more clinics is not going to help me bring costs down. I can't, like I said, can't birth more PCP. But really, like how we bring costs down is through virtual PCP, like give you a PCP in your pocket to build a relationship with that woman. That's how we think about it.
And how are your PCPs becoming the virtualists in a way and become more specialized in the women's health and needs? How are you approaching that? Do you have like a
I think the sort of like going back to why I started a business in the first place, women's health is so fragmented. I'm sure like everything else is fragmented in healthcare, right? But when you look at my own personal journey, it's like the PCP and the OB, right? Like it's really frustrating when you think about, hey, like anytime you go to a PCP, you talk about anything slightly more complicated than birth control, they'll route you off to your OB. I'm like, wait, but this is my everyday issue. Right? Like when you talk about like heavy bleeding, the M word, menopause, or like anything that's a little bit more involved than the simplest birth control, they route you off. And that was my issue, right? So the unnecessary fragmentation was really broken for myself. And the way we fix this is by basically recruiting for a group of PCP who are either trained in women's health or they're motivated. After we recruit this group, we train all of them. So they all go through our own training on women's health to sort of like supercharge them with women's health knowledge. That's why they're comfortable treating our patients from first period through menopause, no matter what it is. That's our approach.
Okay, that's fantastic.
Yeah, on the topic of different approaches, I want to bring Allon, Mr. Access here, telling you Mr. Access, because your approach, Alpha talked about, this is really strange, Archana, with the nicknames.
I know.
Alpha talked about really zeroing in on combining the primary care physician and OBGYN and other resources that women need. And she really wanted to solve that. And Allon, you wanted to solve access. When you said, I'm going to change primary care, I'm going to solve for access. Talk a little bit about that and why that was so important.
I think access is part of it, but it's part and parcel. Access, by the way, is both quality
24/7.
But access is just, and I think the context there around access is, if I've got any kind of medical need, a curiosity, a question, or I need medical advice, or I want to solve a problem, but I might not necessarily need doctor just information. I wanted to be able to press a button, just like I order a vacation in Fiji or order food or trade cryptocurrency. So if we can do all those other things, I felt like we should do this. Look, I think everybody here is an ally to making a change, but we're talking about an industry called healthcare, which is really big in the lip service department of making change. Dr. Pearl mentioned a bunch of companies. What unites all those companies, it didn't come from the industry. And so I've been, a lot of doctors laughed at me in the beginning when I said I want to teach a machine the language of medicine. And a lot of times people didn't take us seriously, and I'm not a fake doctor. But in the beginning, when you're in front of a real doctor, I felt more like an imposter because I didn't study medicine or build a big health system. I think the issues are more fundamental in medicine because it works in an industry called healthcare that, as Dr. Pearl mentioned, I think completely lost the plot on what needs to be done. And I'm now 5 years in this, so I've got a PhD, I suppose, but I hear again and again things that I think are not congruent with reality. I think there's a lot of talk about AI and data. The vast majority of doctors that I met that spoke to me about it actually don't understand how data is used in other industries and what AI is. It's used very loosely. Innovation is used very loosely. And I think most of the time consumers and just everyone mixes kind of true innovation, mRNA vaccines and world-class devices and world-class processes and surgeries with the mundane of medicine. And the reality is, on the core of primary care, chronic care, acute care, preventative care, I don't think it's changed since the middle of the 20th century, since the Framingham study. It's kind of a long time for something really big and important. The one thing on the core delivery that has changed is the cost. It goes up 10 to 12% compounded every year. And so all these things made it really, really difficult. If you ask most people who doesn't have access to healthcare, they'll say, well, people who are uninsured and can't afford it, etc. You've got about 70 million people that are on high deductible plans. So that's one way to defray the cost of healthcare, increase the deductible. And when you do that, people don't handle their hypertension, as Dr. Pearl mentioned, and diabetes and other things. So we've got this convoluted system. You can be the best doctor in the world with the best intentions, but if the system colludes to make it really difficult for you to give care, that's really tough. The other thing is, I've just never quite understood the closed clinic, but the body's open. Your body works 24/7. You might have a small problem and you want to do it after hours. You might have a concern about a big problem and you need to do it right now. But I never understood the fact the ER is open, but again, it's super expensive, super time consuming, and probably not relevant for a lot of different things. So how do you get 24/7? It should be really easy. Again, if we can trade super complicated derivatives in the middle of the night and plan complex trips all over the world and maps and navigation and commerce and all these different things, why are we stuck with, Dr. Google and WebMD when it comes to our health? Like, to me, that's, mind boggling, but also just sorry, and a little bit on a tirade, but we use things called electronic medical records. That's kind of the mainstay of doctors. Those are not medical records. Those are billing and workflow records. In fact, there's very little medicine there, and there's a lot of complexity there about billing. In most hospitals that I've met, they've installed several different EMRs that don't talk to each other. But again, they should be called billing and workflow systems. They're not medical records. They're very partial medical records at best. But everybody seems to live in peace. Doctors use their main get reference guide is called up to date, but it's not up to date, it's out of date. So everybody makes fun of Elon Musk and self-driving and autopilot. Well, doctors are using their main reference guide is a system that they call up to date that isn't up to date. And so these are things that maybe you need to be an outsider to pose those questions and ask them. But I think we need to really soul search to solve the problem. America has probably the collection of the best medical institutions in the world for last result, for tertiary care, for some integrated care. But on balance, I think we do a really mediocre job, a below average job compared to other countries, and just very, very, very expensive, and it adds up. So access matters, affordability matters, but quality, and just also being able to look in the mirror and say, okay, if we call stuff, if we call this spade, let's a spade be a spade. And I think we have this big gap here in this, and this is not going to be fixed just by X or Y. There's no one line that will fix. The problem is not one thing. There's multiple things, that need to be fixed, and from the ground up. So our approach is, of course, and we need to work in the industry, and we need to work with patients and doctors, but also we're trying to build a system that is a system, frankly, that we'd want to use for our families. Again, sorry for a little manifesto, but that's kind of my view of things.
We'll take a deeper dive into that, and obviously the economics for the doctor, the economics for the consumer. But I'm going to punt to you, Archana, because I think you wanted to ask Matt a question.
Yeah, I would like to ask Matt around, your approach is quite unique and different, and still addressing primary care, which is having that dedicated PCP as the face of Eden. So how are you combining that or fluidity between your virtual and then in person, and still be able to keep that trusted, dedicated source or provider? And then how do they integrate with their allied team, or I just say care team?
Yeah, so I think a lot of these points are sort of similar to how we synthesized the market. When I think about what works in healthcare, it's that we have excellently trained clinicians who don't have the time to spend with people that they ought to be able to spend with them, and don't have the longitudinal relationship that they ought to be able to have with those individuals. And so everything that we do at Eden is really in service of deepening that relationship that you can have on a one-to-one or a one-to-a-couple basis with a patient, recognizing that individual is likely dealing with their health issues over days, months, years, decades, not over the 10 minutes you have in a in-person encounter with a provider. And so, ours is kind of basic. You have a usual provider, and that provider is a provider you're going to go to for 90% of things. And then you have a care team that works together with that provider, that works together frequently. They do clinical huddles, pulling from great best practice in terms of, excellent medical institutions. And that care team is who you go to when it's off hours, and when you have things that are acute, where we're not expecting one clinician to stay up 24/7. And then it's about building both technology, but also process and other specialties into the workflows that the providers have so that they're fingertips, excuse me. So if you're a clinician, we think that you're really good at the clinical diagnostics. We think you're really good at developing that patient relationship and beginning the process, but it's very difficult to have a provider who is somewhat costly be that person who's there all the time. So how do you have a system that prompts and supports, with whether it's care navigators or the technology itself, people to be there over the long term? And then bringing in mental health. I think that mental health for us is so core to everything we do, but where you're identifying 70% of mental health issues at the primary care level, but where you're failing is the actual transition of services to a longer term mental health care provider, because who knows who to go to and those providers aren't available. So integrating that type of service and other specialties at the fingertips of the clinician so you can leverage them in a really cost efficient way. I mean, I similarly think we're day one in terms of what's going on in healthcare, because there's very, very, very few organizations that are purpose-built virtually, and also few that are purpose-built in a hybrid environment. But we strongly believe that virtual can be a huge step forward for a lot of things. And then where you can deploy a hybrid experience where you're flexible in the virtual way as in addition to physical, because no one here is denying the importance of physical access to care, depending on what it is. That's really the gold standard. And so our whole model is just, how do you enable that relationship and then provide services in a seamless way that's going to make the rest of that patient experience and make the rest of the provider experience very simple.
Do you measure that? So for example, we do the NPS and other things. Do you have a trust score that you look at because you're focused on that, like you're acutely focused on that? And then the other aspect is provider satisfaction, because I'm pretty sure I've worked in an integrated medical model with crossover health, which does include the components that you were talking about. And that personally, I felt like it was a very satisfying model for myself, and especially mental health should never be away from primary care, by the way. That's where we went wrong altogether so many years ago. But wanted to hear, like, how do you measure both the patient and provider, talent retention, for example, and how does your approach change that for you?
Yeah, the beauty of virtual as well is you can actually have high fidelity measurements on a lot of different things, and you can access measurements outside of what you get in an in-person setting, which I think is pretty exciting. So on the provider side, we see that providers like it a lot more. We give them the ability to be with their patients over the long term. And that's one thing that I think a lot of providers, not necessarily in the Kaiser system, but certainly elsewhere, are missing, is the longitudinality of that relationship and feeling like, oh, I did this, but what's going on with my patient? A lot of that is the satisfaction of understanding over time that you've helped somebody. Additionally, having navigation and specialty care access and mental health is just, I think providers can feel defeated in the rest of the system when they feel like, oh, I know what needs to happen, but I actually can't get you the resources and I don't have time to spend it for you. And so when you can bring those resources to the provider, you sort of change their experience of saying, okay, I know what you need to have happen, and I have confidence that this next step is going to get taken in the appropriate way with team members and a system that I trust. I think that that's extraordinarily powerful. And we see that with extraordinarily low attrition rates of our clinicians. And that's something we measure, and we measure provider satisfaction, of course, on an ongoing basis as well. From the patient side, what the measurement there is really compliance with their care plan. that is the true measure of, I think, of trust and whether or not we're actually doing a good job. But we measure the softer things too. So on the patient sat side, we average about 4.95 out of 5 stars. We talk about, we also see if patients would recommend us to family members as parts of care. We see a repeat behavior that's really high. So our average member uses us about 5 times per year. And so we see for a clinical encounter, and so we see we're both moving care from the specialty side into primary care, but also engaging in repeat utilization. And so I think that these observed behaviors, attrition on the provider side for sure, but we never want to get there. But then also on the patient side, seeing if they're following through and coming back to you, that's the measure of trust in our perspective.
So Allon, it seems like Gloria and Matt are really trying to rebuild or really focus on the trust that patients have with their doctors. They're in the majority of people who registered for this event said they want a primary care doctor. They want a relationship with a primary care doctor. You're going about it a different way, right? They don't come in by finding a doctor. They come in by talking to a K-Health chatbot. Are you going for a different demographic, or how are you building that trust? Because you still need that trust. Whoever you're talking to, whether it's a chatbot or a doctor or urgent care doctor, you still need to develop that trust. How are you going about doing that? And then I want to focus on economics, but first I want to ask you that question.
So you mentioned a few things here.
Yeah, so how do you develop that trust? Because it sounds like Matt and Gloria both really want to maintain that trust between a doctor and their patient, whether, even though it's more of a broader care team approach, whereas you're taking a different approach. Yes, a person can have a doctor on K-Health, but in many ways they're engaging with a K-Health chatbot.
Yeah. Look, first of all, I really I don't know Gloria's business, but I know a little bit of Matt's business, Eden Health. I think it's a fantastic business, and I think that's a great role model for many companies. And we're not really competing. I think the market's so big, as Matt mentioned, we're in day one. I think we're like in the first 40 seconds of the second hour. We're just getting started here, and this is going to take time. Just to be clear, medicine and healthcare are a tougher industry. It's really important. It's really big from an economic perspective, but it's really important. We're talking about people's lives and people's feelings. And, so I think it's probably order of magnitude more complicated than, commerce and even transport. That's, really big and, complicated. So first of all, just to be clear, we've developed a model that when you come into K, if it's around acute stuff or around chronic stuff, we try and collect information as much as possible and let you choose if you want to speak to a doctor or not. Most people want to speak to a doctor, and we take that information and lay it out in an electronic medical record that focuses on medicine and not on billing. So in that respect, we're similar. We might have a different funnel of the way people come in. We are thinking about cost and scale. So if you go to a doctor or a nurse or let's say a minute clinic, and you come in and you say, why are you here? My head hurts on the right side, it's pulsating or radiating or all these different questions. If a machine can collect them and also consider a lot of rule out and just collect a lot of medical history background and understand the clinical setting, maybe we have it already, maybe we don't. That's expensive to do. We do it at a scale that's big. And we plan to do it at a scale that is really big. And so, if I would like the doctor to focus, and as doctors are fond of saying, at the top of the license. And not only I don't want them to do any administration, but if an intelligent machine can collect information and assemble it and put it in front of a doctor and organize it in a way that's easy for a doctor to understand, I'm for it. Of course, doctors are doctors just like any other doctor, have their responsibility on, establishing care, diagnosis, and treatment, just like anybody else. Look, regarding the single primary care that I know and trust and speak to, I can certainly see the pluses of it. but I can also see the minuses. So first of all, we all think of the doctor in I don't know, in the village where everybody was super happy and you knew your doctor personally and you went to see them all the time. The reality is most people don't know their primary care unless they have a chronic condition and need to go in, very often. So kind of be careful what you wish for. I think you want an EMR that truly knows you and can understand you and can route you accordingly. And Gloria described, complex routing. That's all too often. So for me, I'm thinking about it more of a system. I'd like to enable you to come in, manage your acute, manage your chronic, manage labs, avoid stuff, and do it in a single system. I think many times, and I'm, would love to hear doctors' opinions about it. Sometimes it's better that different doctors see the same patient. Why? Because every doctor has a slightly different judgment, and some of these things are really complicated. So actually, sometimes it's better to have different doctors. I think we will have care teams in certain areas. We have now gone into primary care. We're early days into it. That's absolutely, something on the table. But again, if you want to see Dr. Pearl, and Dr. Pearl is only available in 4 days because he's busy and he's booked up, then again, what are the choices here? And I think if you've got a care team that's appropriate for the kind of medical setting that you're in, and you have a team that uses a single EMR and can fully understand what other doctors did that and can look up your medical history and interactions with the system, I think it's a huge plus. I can tell you that we've seen many, many cases that people come to us after going to experts externally, and they go to 2 separate experts, and the experts don't talk to each other. They use the same, it might get shared in the same EMR, but they don't talk to each other. So people get 2 different medications that are conflicting with each other because it's really, really tough, even for good doctors, to work on a clunky EMR. So I think our approach is building a single system, giving the power to users, to consumers, to take control of the system, allowing them to press a button and to call the system. But I would not want to have redundancy in having great doctors sitting around, because that's a very, very expensive resource. And I want to give people the opportunity to resolve their problem, right now. So I think it'll, and money does matter, because you want to try and keep costs down. So if I'm going to build massive redundancy, then again, the costs are going to go up again. And, doctors are expensive for good reason. They're highly educated, and they should be focused on, judgment and, decision-making. And sometimes
I talked about in the very beginning is that economic incentives matter quite a bit. Dr. Pearl mentioned that the economic incentives matter quite a bit, and you're doing that to some extent because your physicians are salaried, so they don't get paid per visit. Do you have at some point, will you be integrating that type of payment into some sort of value-based care, so it's based on outcome?
Yeah, look, again, every company needs to start from somewhere. We started from the big somewhere, the big niche of kind of acute care, and expanded into chronic care. And we started with out-of-pocket, but as you know, we've got a big partnership with Anthem and Blackstone called Hydrogen around going into the employer market. So we're absolutely thinking about different models. Again, this is where I completely agree with Dr. Pearl. You set a certain incentive and the culture follows around that incentive. So I really think actually Medicare Advantage is often a much better approach than the traditional fee-for-service that is prevalent in the commercial center. Everybody said, when I started K, everybody said big companies are self-insured, it's their own money, they're very sophisticated. The government doesn't know what it's doing. The government actually, Medicare is way more sophisticated than big companies. They understand the business, they negotiated better rates, big companies pay worse rates. But absolutely, I think the capitation models are much better, especially if you get them right and then you actually focus on health. Because everybody typically tries to game the system. And you need to remember that there's a lot of money and a lot of incentives.
I have a question for Allon, followed by a question for the rebel here. So the question for you is, yes, in the back end, you're paying the PCP and on a salary, but on the front, what the patient is perceiving is that he got $9 for a PCP. access to a PCP. Are you creating a perception of downward value for PCP for the patient who is truly the consumer? And then the follow-up question for Robbie is like, should we be paying the cardiologist that $9 and then paying the PCP the $30 and flipping the model a little bit? So Allon, we start from you and then we go into discussion.
So I'll keep this short. I don't want to monopolize the panel. Only in healthcare, people will ask me why I'm lowering prices.
Yeah.
The price of visiting a doctor, $150 exchange hands in America, whether it's big or small. Once you go in, you're paying your copay and your insurer pays the rest. It's $150. That's about 3 times higher than anybody else. That's the question you should be asking. If we can lower the price and make a business out of that using automation, it makes sense. Bear in mind that primary care clinics don't go there and make these huge margins. They're usually actually so burdened with billing and admin, et cetera, and manual paperwork. Go into your traditional PCP and take a look there. It looks like 1985. They paid it out to, but they spend all this money on hiring all these people to do all this manual work. So for me, lowering the pricing is something you want to encourage. A lot of people can't afford going to doctors in America. And that's the key question. And just like in many other areas in technology, if Amazon or Walmart or other companies are able to take advantage of scale and lower pricing, that's important. People sometimes think, well, you get what you pay for, which I think is probably invented by Gucci or somebody like that. But I think we rack really high in quality of medicine, and we can see quality of medicine. I just want to point out another thing, and I think you or Bambi asked me last time, how do we know our doctors are good? Well, our charts write themselves. The doctors don't write the charts. They texting with patients, and that information gets collected. There's no summary of chart because we have the full chart. So we are able to audit the doctors in a very detailed, specific manner in a way that doesn't exist in other settings when somebody walks into a clinic and has a verbal conversation, and maybe there's a scribe. So my premise, and this is the last thing I'll say, my premise is, I think medicine could be significantly cheaper and much better all at the same time. Why? Because it should use technology and data. It should use doctors appropriately and should route people appropriately. And again, that's going to take 10, 20 years, not 1-2 years. It's going to take time to build it right, and it's complicated, and we need partners, and it's complicated, and medicine itself is complicated. But I just think the premise of why you're lowering prices should be, everybody should be super happy if we can keep pricing low.
Well, it's different. So the question, and I will put it for Robbie or Dr. Pearl to answer. It's like by having lesser cost upfront for primary care, are we creating a perception that this is the Walmart and not the Nordstrom of care, when actually it's the other way around? Like your primary care is like your higher value, but we are dropping down the price.
I'll dive in, and when Atesh Rastogi, he and I founded OnLive, and I wasn't looking at the time to found a new company. I had been CEO for a while, but it was so exciting because it was an opportunity to be a solution, because I think it's the wrong question you're posing. And what I mean by that is the following: physician salaries are a small part of the total cost of healthcare. We should be paying primary care more, and we should be paying specialists a little bit less. That's what we did in Kaiser Permanente, but that's not the big issue. 30% of healthcare has been shown by the Mayo Clinic to add no value. You start doing 30% of $4 trillion, that is where the money is. So now you got to ask yourself, okay, if 30% is the problem, how do we get there? And it's why we're not starting just with primary care. It's primary care and specialty care and these care associates to now coordinate that process and provide concierge care that 80 or 90% of Americans can afford. You bring this, you have the primary care, what Allon said was absolutely, or Matt, one of the two said, the notion of the ED at night. Yeah, it's crazy. We shut our machines and tell patients to go to the ED, whether the information is not available, the cost is much higher. They often spend the night in the hospital. The solution is you take 20 primary care physicians, you pay one of them to be on call at night every 3 weeks, and now you can provide care. We did this in the Mid-Atlantic, Kaiser Permanente. 70% of the time we solved the problem that night. Technology, Allon is right. You know, in dermatology, when you have a patient with a rash that the primary care doctor can't diagnose, they sort of know what it is, but they're not sure. What do we give them a choice today? They decide it yourself or send it to dermatology. You take a picture digitally, you send it to the dermatologist, and in 1 minute you have your answer. Care is immediate. 6 minutes was the turnaround time, not 6 days, 6 weeks, or 6 months. That's the inefficiency that's there. When you bring the specialist into the primary care office, you get the coordination of care. And 40% of the time, they never see the specialist. And what happens in American medicine, we don't talk about it. You see a specialist, I guarantee you, you're gonna get lab tests, you're gonna get x-ray tests, you're gonna have a return visit, and you're probably gonna get a procedure. Why? Because that's just the way it is culturally in the United States, whether the outcome is any different. You know, what do we know? Neoarthroscopy. If you do a controlled experiment, you do an incision and close the incision. We do the incision, you put a scope in, trim up the cartilage. 1 year later, the outcomes are no different. The most common operation done in the United States today. This is where the problems are sitting. And then if you need a procedure done, because you had the consultation already, send it to an expert at a center of excellence who has a high enough volume. Half of the laparoscopic hysterectomies in the United States are done by doctors who do fewer than 10 a year. You never would want it to happen. Patients just don't know. Slower, poorer quality, complicated. I can go on and on through the systems that are there. You know, we should be probably paying, instead of 6% of the total healthcare cost in primary care, it should be 12. And primary care doctors, instead of making 200 some odd thousand, should make $300,000. Why is that? Because they can add the value, but the system doesn't let them do it today. As soon as you have a specialist come in the room to give the 5% of information that the primary care doctor doesn't have, now they can solve the patient's problem. That's tremendous value. And I agree with you. Culturally, what we have done is to knock down primary care. Who gives every lecture in medical school? A specialist. Mm-hmm. Why shouldn't primary care be giving it to medical students? Primary care doctors know how to take care of atrial fibrillation. They understand, issues around pulmonary ventilation. They could give the lectures, but we don't do that. So I think the diminution of primary care is culturally starting in medical school. It goes through the roles we give them in society, and the lower revenue actually, I think, comes from that. But I believe that if we can change this whole system, and now primary care doctors are able to manage 24/7, no one doctor, but a team of doctors. And now you have the specialists coming into the room, so the patient's problem was solved adequately, and they can provide the continuity of care in chronic disease to take out what is, depending upon your estimate, 40, 60, 80% of healthcare costs. You go down the list of places, you elevate primary care to the role it should be. That's why I start with the statistic. 10 primary care doctors added to a community, raises, fit it 2.5 times. Why would we not elevate that specialty in importance? Sorry, Allon.
No, I completely agree with everything you said. And by the way, I just want to point out for people who didn't come from healthcare, if you spoke about another industry where the most reputed, probably the top institution, Mayo Clinic, said a third or 30% of healthcare has nothing to do with health, or it's wasted, or whatever it is, and it's over $1 trillion a year. That's like a COVID relief every year. People will be up in arms. If you bought food or bought a house or bought any or used transportation, if buses and trains were running empty a third of the time, and you'd say, why the hell is that happening? People will be up in arms. But here, that is a core question. And you're saying all the right things. Being able to fix it, this is systematic. What you're describing, getting rid of this desire to go directly to an expert because they know everything and not primary care, this integration, this is not trivial to build. You need to build it from the ground up.
Yeah. So let me add that I think the 30% you're talking about are administrative costs, right? And
no, it's combined. It's It's unnecessary
And
or
unnecessary, yes, unnecessary.
overprescribed.
Prescriptions.
Yeah, I mean, yeah.
I want to bring in Gloria and Matt because they've been so quiet there. But to sort of piggyback on those questions, how are you both elevating the role of the primary care doctor, not just perceptually, but also economically, but also increasing utilization on the front end by the patient or / consumer in an economical way, an attractive way?
So Gloria, go ahead.
I think you asked Gus.
Yeah, so I think, I mean, I think the question is not like, we can all agree that we need to elevate the role of a PCP, right? But the question is like, how do we do that systematically? Like, I don't, so like when I had my issue, or I actually just broke my leg earlier this year. So, I don't belong to Kaiser. So it seems like I went to the wrong system, therefore the fragmentation, right? Therefore the lack of communication between PCP and the specialist. So I think like, how do we do this and how do we encourage consumers to consume more PCP? I think it's not something that you fix from medical school and God knows how long that takes, right? The residency programs, and that's the policy, not us. But I think from a consumer standpoint, how do you encourage them to consume more PCP, to think about, hey, like, instead of going to an ER, instead of going to the ED, you actually go to a PCP. So fundamentally, it is access, because like 1 in 3 women of reproductive age, they don't have a PCP. So when you don't have a PCP, you go to urgent care. That's what you do. I think it is about like educating them, giving them the PCP, giving them the doc in the pocket. And the way we do this, which might be similar to others, is that, hey, when they have an acute issue, when they have a issue that they perceive as acute, you give them a doc and you turn that person into the PCP so that they come back, right? Like, hey, a woman come to us for UTI, or like they come to us for whatever, and they've experienced the care and they come back for other things like asthma and mental health and whatnot. And that's how we encourage the consumption. And that's how we encourage the utilization of a PCP. You start by going after what they perceive as acute, not always actually acute. So that's what we do. But I don't think it's on the supply side. I don't think it's something that we can change in the medical school system or training residency program, salary. I don't even think that's the majority of the issue. It is like the consumer perception and utilization.
I think I totally agree with you, Gloria. I think consumers need to be more proactive about their health. But there's somebody here on the chat line. Everybody can see it. They're referring to their children. I have 4 kids, so I totally understand this. Children are sick often, and aftercare appointments, it's hard to connect with your doctor. I know I'm at Kaiser. Sometimes I can't get an appointment right away with that specific doctor, maybe a doctor, but not the specific doctor. As a parent, you do end up going to urgent care. You do end up going to ER. So it's not just from the patient side. There is these access issues and educational issues, because clearly not everybody knows that there's a K Health or Alpha or Eden Health. They just go right to their urgent care or retail clinic or emergency room.
Yeah,
So,
I mean, I think that we're almost overcomplicating the question in some ways. To me, people talk about primary care having a reduction in terms of people focusing on it, people with fewer primary care providers. Basic reason is we made it hard to access. It's easier to go to the ER. It's easier to go to urgent care than to go to your primary medical relationship. I think that's a huge problem. And so just making it accessible, people trust primary care. We see that day in and day out, patient after patient. And if you can just make it accessible, that's sort of the basic framework. The second piece is we also know what to do from a population health standpoint. Pretty much our entire disease burden is blocking and tackling basic health issues that we've known how to deal with for a really long time, but it's hard to change behavior. And so how do you do that? It's you provide a trusted relationship where you can help somebody make it through the times that are difficult, to say, change eating patterns or negotiate a conversation with their family where they have to do things differently around nutrition, or introduce a mental health support. I mean, these aren't complicated interventions really at all. So I frequently go back to, how do you fit in this different way of paying for care? Because there's really the incentive structure that's doing that into the existing ecosystem, because, I want us to promote at a high level a lot of policy change around this, but at the same time, you can take advantage of today's structures and today's incentive models, and you can introduce the care that we know how to deliver very effectively. And then you can leverage existing technologies in the market to do it simply at a low cost. We're not a premium price. We're making similar amounts to what an effective doctor's office is. We're just providing care differently and leveraging staff differently in a virtual format with some other support. It's not that, it takes a lot to build, but I do think that the answers are basic and ones that are well recognized.
Let's ask a question here for Dr. Pearl. What worked well at Kaiser and what didn't?
What worked very well at Kaiser Permanente was, number one, the capitated model of payment. It was over 90% capitated. Number two, the integration of all the physicians working together in ways that provided the care. And that's how we achieved, of the 1,000 programs in the United States, we were number one in overall quality by the NCQA. It was the use of technology that existed at the time, and a leadership structure. There is no structure in most of medicine today. There I was a CEO. I had heads of each of the facilities reporting directly to me. They had chiefs of departments reporting to them. You're actually running a business that's coordinated instead of running a 19th century cottage industry that's paid on a piecemeal basis like we had. What didn't work? We couldn't scale. We were stuck in California, stuck on the East Coast. Several places that we went to, Kansas City, North Carolina, Texas, we ended up having to close. And again, that's what brought me to OnLive with Hitesh, because the opportunity to use technology to be able now to scale, to not have to build billion-dollar buildings, to not have to hire all your doctors in one geography, to not have to accumulate all the patients in a given area, that was exciting. And I think if you want to think about it this way, the opportunity to build a virtual Kaiser Permanente. What frustrated me was the bricks and mortar Kaiser Permanente. That was wonderful as long as they were there, but it couldn't expand. Technology has changed all of that. And we haven't even yet talked about AI and wearables and the other things that are going to add to it. I just used telemedicine as the first piece, the foundational piece to connect all the disparate parts.
I want to quickly ask Matt, because we didn't really get to it, because you have an interesting model going into corporations and
I just apologize.
like clinics, correct?
I apologize. Yeah. I need to run.
Oh no, Allon. You have to tell us one truth that that no one agrees with you on.
So many people don't agree with so many things I said here. So, this is a fun panel. Thank you. Good to meet you all.
Nice to meet you, Allon. Thank you.
Okay, we're gonna wrap this up anyway pretty soon, but Matt, really quickly, how is it going getting into corporations? What's the value proposition to them? What's the challenge? Why don't they want to open an in building clinic?
And on-site health centers, and then also your experience with the pop-up health center. We would love to hear about that.
It's a 45-minute question, but we'll do it quick. So look, employers have the ability to buy care differently. That's just, they sort of are their own little decision-making entities. They operate in a much larger world, obviously, with those pressures, but they can kind of one-off make decisions. That's why we started with them. And they're able to do that. And for them, they're looking for experience, a high quality experience for their employees. We know that drives better health for them. We know that they care about retention and attraction of those employees. And they're also looking to do it at a reasonable price that ideally saves money. And so speaking to them, and I think in simple ways where you have a high quality experience and you can also drive savings, is a pretty straightforward engagement. For the employers, we're a bit flexible. So most of our clinics are near site, so they're shared. So you don't have to build out a large center at your facility just to have access to our physical sites. But we do offer those private locations, and that's really if you really want to go deeper. And then we have mobile providers, and those providers go flexibly to the work sites. Let's say you've got 15 locations around the country. Our providers can go there, take over a conference room, provide care there directly. That's really about bridging the gap between virtual and physical. Because as great as virtual is, there's benefits to physical access, and especially benefits to exposing people when you are in an in-person setting. But we've also brought this model outside of employers. So to TPAs, we'll be announcing PEO partnerships as well as on the carrier side. So that's really where we started, and we're continuing to double down there as well as bringing it externally.
That's fantastic. And are you value-based modeling, or is that like a membership, more like a per member?
I think there's a scale on the value-based piece, right? So on the one hand is, do you have accountable outcomes that you're reporting against, and do you have fees at risk? Yes, we do for pretty much all of our accounts. The second piece is, do we have, are you participating in some level of risk and or shared upside or shared savings? The answer is that for us, yes, for us as well. And we're looking at total cost of care options, and expect over time to be implementing those.
Okay. That's fantastic.
All right. I think we need to wrap this up, Archana, because it's 12:33.
Yes.
And we have David coming up, but I do want to end with that question because I think it's a little interesting one, and also one where you guys can just riff a little bit on some of your vision, what that nobody agrees with you on. So one truth that no one agrees with you on. So Gloria, we'll start with you.
Yes.
Well, so many. Where do I start? One thing that I think about all the time is that, hey, like Allon talk about this a little bit. Everybody, when you ask them, hey, what's your favorite brand of, like, what's your favorite restaurant? What's your favorite brand of car, right? Everybody can name one. With PCP, most people can. And I think that's really important in like consumer education, like building a brand for primary care so that they actually know to consume primary care. They actually know, instead of going to the ED urgent care, you go to a PCP. So I think the space it's just the beginning, right? Like whether it's a brand for primary care or a brand for women's health, right? Primary care for women, I think that needs to exist. And it seems to be very much forgotten, I would say.
Matt?
I guess I'll go back to something that I kind of shared a little bit earlier. I do think we have all the pieces that we need in the system today to just transformatively provide different kinds of care. We know it happens in certain areas, in some cases on a very large scale. And so I think it's just considering the incentive structure, making sure that your economic model works with that, and then just providing the kind of care that's longitudinal and oriented towards the long-term health of the individual that we need to do. I really think that structure is here today and needs to be implemented.
Okay, Robbie, something people don't agree with you on.
That the problem is solvable. I think a lot of people believe that medicine is just too complex, it's too big. Doctors like herding cats, and go down the whole list of pieces that are there. I don't think we've done a good job of approaching the problem. I think, as someone said earlier, if this was any other business besides healthcare, every one of us would be fired because the job we did would be so poor. I don't mean the people on this panel, but this is the American healthcare system. We spend twice as much in any other country, just about, besides Germany, Japan, and Switzerland. And the results that we get are the worst. We have the lowest life longevity. We have the highest childhood mortality, the highest maternal mortality. I can go down the list of pieces. It's inconvenient. It's overpriced. We haven't done a good job, and that's what I believe. And I think you heard some really good thoughts on this panel. I think everyone who spoke on this panel had a really solid plan, which is exactly the best plan to get there. I mean, some of the people talked about an on-site location, some were technological, focused on women. My belief is you have to have the entire elevator. You have to have the specialist and the primary care, because together they're so much more powerful. That one, the primary care, I tell people, I'm a specialist, but I tell people primary care, 70% of the value, but specialists have 80% of the cost. And if you're not taking both those at the same time, I think you're going to end up not getting as good a result. That's why I'm excited about OnLive being able to accomplish that. And you have to figure out how you're going to support the physicians providing the care. And I think that's a question I saw on the sideboard right now. Primary care is undersupported. It can't do the job in the United States today. I think panel sizes need to be smaller. It needs to have support. And one of the things that's really exciting to me about, again, the model that we have is that the people that we're using are highly skilled, and their cost is about 1/5 of what exists in the United States today. So you can give twice as much care for half the price. And I think once primary care physicians have that support, You're going to see remarkable results. And over time, it's going to evolve because you're going to have clean data that's going to allow you really to apply AI in positive ways. And I think you get into a virtual system. I'm really excited about what I heard from Matt and from Gloria and from Allon, because they all have other great ideas. I am a rebel because I believe that American healthcare should be the best in the world. And I think that everyone on the panel today is trying to make that happen. So my thanks to the other panelists.
Awesome.
Thank you. Thank you too.
And
So-
thank
Thank
you.
you.
And any closing remarks from you, Bambi?
Closing remarks. I think that, hopefully the takeaway here, everybody heard, is that we need to work on the economics. We need to really think about how do we drive incentives to primary care so the patient will utilize primary care more often. So I think the economics start, and then we'll consider that will change the culture, that will also influence our technology. And I'm excited that we have a whole room of people here listening and also speaking to share their ideas about how to move the ball forward. That's my thoughts.
And I feel I loved variable models, and I know patient is an average Joe. And that's exactly like for primary care, we would need different versions of it. And at certain age, they will adopt a certain business model or a certain way of delivery, certain gender, they will adopt it differently. So we need more and more innovation and more diverse innovation in primary care. So I loved that across our panel. Thank you so much. Thank you very much.
Okay.
Thank you.
Thank you, Robert Pearl. Thank you, Matt. Thank you, Gloria. Stick around, please, until 4 if you would like. We have more of a conversation with physicians and VCs, and of course, the startup presenters. Now we